Let's now move on to discuss the medications that disrupt folic acid synthesis in bacteria, including the sulfonamides and trimethoprim. But before we begin, let's remind ourselves why folic acid is important. Folic acid is required for the synthesis of purines, adenine and guanine. It is also required to convert uracil monophosphate into thymidol monophosphate. Do you remember what enzyme catalyzes the reaction from UMP to TMP? That would be thymidylate synthase. Very good. If we think back to oncology, what chemotherapy drug inhibits this enzyme? That would be 5-fluorouracil. Very good. So in review, folic acid is required for the de novo synthesis of purines, adenine and guanine. And it's also required as a cofactor for the conversion of UMP to TMP by the enzyme thymidylate synthase. To really understand the mechanism of action of trimethoprim, we need to have a good understanding of the folic acid synthesis pathway. Here we have the two substrates, PABA and pteridine. These molecules are turned into dihydropteroic acid by dihydropteroate synthase. Dihydropteroic acid is converted to dihydrofolic acid, which is then converted into tetrahydrofolic acid by dihydrofolate reductase. Can you point to the spot in the synthesis pathway where trimethoprim acts? Very good, it acts on dihydrofolate reductase. Trimethoprim is frequently used in combination with sulfonamides, such as in trimethoprim sulfamethoxazole, also known as Bactrim. This drug is commonly used to treat UTIs, and it can also be used to treat Salmonella and Shigella. It's important to remember that these are bacteriostatic drugs. Do you remember why trimethoprim sulfamethoxazole is used in an immunocompromised patient? The drug is used for prophylaxis against pneumocystis jirovecii and toxoplasmosis. An important side effect of trimethoprim is that it can also affect human dihydrofolate reductase. Now, why would this be bad for us? Well, remember, folic acid is key for our own DNA synthesis as well. Reduction in DNA will lead to a limited ability for our own cells to divide. If we think back to immunology and hematology, reducing nucleotide synthesis can lead to a bone marrow suppression. With bone marrow suppression, there would be a reduced production of immune cells, which would lead to a granulocytopenia and a leukopenia, which means a lower number of granulocytes and leukocytes. Here is a classic image of bone marrow suppression. We can see that the bone marrow here is filled with fat droplets instead of rapidly dividing cells. Furthermore, it would lead to an anemia because red blood cell precursors are also produced in the bone marrow. Here is an image of a form of anemia. Does this picture fit the characteristic anemia caused by a folic acid deficiency? Well, first, what do you notice about this image? Well, this image shows a microcytic anemia. And how do we know that it's a microcytic anemia? Well, we can see a central area of pallor in a number of these red blood cells, and we can also see that the red blood cells are smaller than these lymphocytic nuclei, telling us that they are microcytic. So with that in mind, does folic acid deficiency lead to a microcytic anemia? Does that sound right to you? No, it does not. If we remember back to hematology, folic acid deficiency leads to a macrocytic anemia. More specifically, it leads to a megaloblastic anemia. Do you remember the mean corpuscular volume you would expect to see in a patient with macrocytic anemia? We would expect to see a mean corpuscular volume greater than 100. Very good. You can use the mnemonic TMP to remember that trimethoprim treats marrow poorly. This will help you remember that trimethoprim can lead to bone marrow suppression and leading to granulocytopenia, leukopenia, and anemia. For this exact same reason, trimethoprim should not be taken during pregnancy. Now time for a flash quiz. Can you guys tell me how bacteria develop drug resistance to macrolide antibiotics? Remember that bacteria methylate the 23S ribosomal RNA, making the macrolides unable to bind and therefore ineffective. The sulfonamides are the other class of medication that interferes with folic acid synthesis. Because this is a very high yield topic for step 1, let's review the folic acid synthesis pathway. Do you remember the first step in the synthesis pathway? PABA and pteridine are converted into dihydrotoroic acid by dihydroteroate synthase. Dihydrotoroic acid is then converted to dihydrofolic acid. Do you remember the next step in the pathway? Dihydrofolic acid is converted to tetrahydrofolic acid by dihydrofolate reductase. Tetrahydrofolic acid is then used for the synthesis of purines, thymidine, and methionine. Now, where in the pathway do sulfonamides act? Sulfonamides work by inhibiting dihydroteroate synthase. And where again does trimethoprim act? It acts on dihydrofolate reductase. The way I remember that sulfonamides act here and trimethoprim acts here is to remember that S comes before T in the alphabet, and that helps me to remember that sulfonamides inhibit an enzyme earlier in the synthesis pathway than trimethoprim. The sulfonamides include sulfamethoxazole, sulfacizoxazole, and sulfadiazine. These drugs are used to treat urinary tract infections and can also be used to treat PCP pneumonia, chlamydia, and nocardia. It's important to know that sulfamethoxazole is typically given with trimethoprim in a combination that is called Bactrim. However, in some cases, the sulfonamides are used alone, as in the case for nocardia. Do you remember the mnemonic that helps remember that treatment for nocardia and actinomyces? The mnemonic is SNAP. We can remember that sulfonamides are used for nocardia and penicillin is used to treat actinomyces. A couple of toxicities associated with sulfonamides are very important for the boards. An important toxicity that is common to a lot of drugs includes hypersensitivity reactions. What are some important hypersensitivity reactions that we have talked about previously? Rash and anaphylaxis are important hypersensitivity reactions that are what are called type 1 or IgE-mediated hypersensitivity reactions. Also, we can see a hemolytic anemia, which is a type 2 or antibody-mediated hypersensitivity reaction. A highly tested topic on step 1 is that sulfonamides can lead to a hemolytic anemia and G6PD deficiency. Thinking back to metabolic biochemistry, do you remember what G6PD does? Well, remember, G6PD stands for glucose-6-phosphate dehydrogenase, a key enzyme in the pentose phosphate pathway. It is responsible for producing NADPH by converting glucose-6-phosphate into 6-phosphogluconolactone. Now, do you remember where G6P comes from? G6P comes from glycolysis. Very good. Now, do you remember why NADPH is important? Well, there are two key functions of NADPH, and I'll go over them here. One, it is used in the synthesis of fatty acids. Remember, NADPH is an anabolic cofactor and is used for the synthesis of fatty acids. Also, NADPH is a cofactor used to replenish glutathione. Glutathione is an important molecule that handles reactive oxygen species in our bloodstream. So back to the original point here, why do we see hemolysis in G6PD deficiency? Well, it comes down to the point right here. We have an inability to replenish glutathione. Without glutathione, we have no ability to quench those reactive oxygen species, and they accumulate in the blood and damage our red blood cells. It's important to remember that glutathione is responsible for reducing the oxidative species, and in the process, it itself becomes oxidized. After it becomes oxidized, it needs to be reactivated or reduced by NADPH. Patients without properly functioning G6PD will not be able to produce adequate levels of NADPH and therefore will be unable to replenish their glutathione levels. Without the glutathione, dangerous levels of reactive oxygen species accumulate and damage our red blood cells, which leads to a hemolytic anemia. But wait a minute, Kevin. What does this all have to do with sulfonamides? Well, sulfonamides, by the nature of their being, create additional oxidative stress that further damages our erythrocytes. In patients with normal G6PD levels, the additional oxidative stress placed by sulfonamides is not clinically relevant. However, in an individual with low levels of G6PD, sulfonamides tip the scales by adding more oxidative stress in someone with low NADPH and glutathione levels, which ultimately causes a clinically relevant hemolytic anemia. Now, what would a patient look like who has a bad hemolytic anemia? How would you recognize this happening clinically? Well, first, they would be showing signs of anemia. They could have pallor, they could have some fatigue. They also could look jaundiced due to the accumulation of bilirubin in the skin and sclera. Very good. I hope you guys found this review helpful. Sulfonamides are also a cause of tubulointerstitial nephritis. Now, do you remember what that is? Well, tubulointerstitial nephritis is actually a hypersensitivity reaction caused by sulfonamides and other drugs that leads to acute inflammation of the renal interstitium. It is associated with hematuria, fever, and rash. It also can cause and be manifested as costovertebral angle tenderness. Do you remember what the classic finding on urinalysis is of patients with tubulointerstitial nephritis? Well, you would see pyuria, or the presence of white blood cells in the urine, and most predominantly, you would see eosinophils in the urine. Very good. Sulfonamides can also cause kernicterus in neonates. To understand why, we need to remember that sulfonamides rely on albumin to travel through the blood. In fact, they actually compete with other molecules for space on the albumin molecule. Imagine albumin as a crowded city bus in San Francisco with all these people, or molecules, trying to get on at every stop. With that in mind, why do you think sulfonamides cause kernicterus? Well, first, let's remind ourselves, what is kernicterus? Kernicterus describes a central nervous system damage caused by the deposition of bilirubin. Now, do you remember why we only see kernicterus in neonates and in very young children? Well, this is because little babies do not have a fully developed blood-brain barrier, and therefore the bilirubin can cross the blood-brain barrier and deposit in the CNS. So why do you think giving sulfonamides would lead to kernicterus then? Well, first, do you remember how bilirubin travels around the bloodstream? Well, it is bound to albumin. So if sulfonamides are competing for the space in the bus, just like bilirubin is, there are less seats for bilirubin to sit, and therefore there is higher levels of this free-floating bilirubin in the bloodstream. So then this poor bilirubin gets lost and ends up looking for places to sit down, and it eventually crosses over the blood-brain barrier and into the CNS, depositing and causing our kernicterus. Also, sulfonamides compete with our warfarin binding on albumin. So if someone is on warfarin and you're about to prescribe them sulfonamides, would you want to increase or decrease the dose of warfarin? Well, you would want to decrease the warfarin dose because more of the warfarin will be free floating in the bloodstream instead of bound to the albumin, and this can lead to potential toxicity. There are two important ways that bacteria develop resistance to sulfonamides. The first way is by altering dihydropteroate synthase, or the enzyme that is inhibited by the sulfonamides. Another way is the bacteria can increase the synthesis of PABA, one of the substrates used by the enzyme dihydropteroate synthase in the synthesis of folic acid. Now, why would increasing PABA synthesis, or increasing the concentration of PABA, make the drug ineffective? Well, if we remember back to enzymatic biochemistry, if you increase the substrate of an enzymatic reaction to great enough levels, the substrate will overwhelm the enzyme inhibitor and cause the reaction to proceed forward. Now, what does this tell us about the type of inhibition of the sulfonamides? Well, it tells us that the sulfonamides are competitive inhibitors. Very good. Now, why does that make sense? Well, if we remember, competitive inhibitors bind to the same pocket in the enzyme as the substrate. So the sulfonamides compete with the substrate for the enzyme dihydropteroate synthase. So if the bacteria increase one of the substrate, or PABA, to great enough levels, like I said, it overwhelms the competitive inhibitor and allows the reaction to proceed forward and produce the product. In this case, would be dihydrotoroic acid.